Hello, welcome to the Standing Committee on Health and Social Development. Today is Wednesday, March 4th, and this is the meeting starting at 1:30. With us today, we have committee members. Heath McDonald is here, Trish Altez, Lynn Lund, Sydney McEwen, and Corey Deagle. So to start, could I get a motion to adopt the agenda? Trish Altez, thank you very much. And just to start, there's a couple of things that I kind of just wanted to recognize on behalf of this committee potentially. Is there's three big things that happened in our community lately, and they all revolve around various aspects of what this committee looks into. So I want to recognize the Holland College women's volleyball team who won the ACAA championship on the weekend. So they did a very good job, and it's been the first time they've won that championship. And today, or on Sunday, March 8th, it's International Women's Day. So the theme this year is "An Equal World is an Enabled World, and it is because of you" from the federal government. So hopefully there's a lot of events going on in your area. And finally, a major milestone for Prince Edward Island. The University of Prince Edward Island Lady Basketball Panthers won an AUS championship for the first time since 1998, and this is a huge accomplishment. They're in Ottawa, and they're playing tomorrow at 2 o'clock. So on behalf of this standing committee, we are watching and wish you well. I'm just going to list off the players who are on it. Jenna May Ellsworth from Charlottetown, Ashley Marshall, Madison Orser, Lauren Fleming from Sussex, Lexi McGuinness is from Prince Edward Island, Reese Baxendale, who was named the tournament MVP over the weekend, Riley Sullivan, Carla Yepes from Quito, Ecuador, Lauren Harris, Annabelle Sharon, Carolina Del Santos, Sydney Whitlock from Charlottetown, and Lauren Rainford. Go get them. We're behind you all the way. So thank you very much. And so we're going to move on with the meeting, and want to welcome our guest this morning. So we're going to get a briefing from Dr. Cyril Moyse, Registrar of the College of Physicians and Surgeons from Prince Edward Island, regarding the medical recruitment and retention in PEI. So he's prepared a slideshow. So take over, and we'll ask questions after or before or during, whatever. If there's a question that you need answered right away, I'll let that go in the middle of the presentation, but we'll keep things moving. So I'll turn it over to you. Thank you.
Thank you very much. Thank you for the invitation. Mr. Chairman, I just want to up front say the college does not recruit. We license, and the purpose of the slideshow is to give an overview as to what we do to try to ensure patient safety, of which registration and licensure is a big part. So we are part of one of the cogs. But from my perspective, it's a conflict of interest for the college to recruit and then to decide whether they're eligible for license or not. So thinking in terms of where the last step before a person enters practice, if we can sort of keep that in mind, I'll give you an overview of the college and some of the issues across the country with regard to registration, which have been quite challenging. As you know, the discipline is part of it, and we'll just deal with this in about 2 slides. The structure of the college is set up so that there are 2 standing committees, one of which is an investigating committee. You could compare it to a police department if you like. They gather the evidence and decide if there's enough evidence to put forward a charge of professional misconduct. Different from negligence. Negligence is a court thing. We don't award damages. Our focus is primarily to make sure a physician is competent. If I make a mistake, is it because it was a one-off thing, or is it because I just don't know my subject? In which case, the college might get involved and tell me I have to go take a course and prove that I am capable. Or, more commonly, it's a professionalism issue and poor communication or something along that line. So the office receives the complaint, communicates with the complainant, then refers to the appropriate committee for their review. But the important part of the afternoon, I think, relates to registration, unless people have something to inquire about the discipline part. We hope to register people who don't need discipline. The discipline is unfortunate, it happens. We all have problems at times, but But if we can register appropriately, hopefully we can reduce the frequency in which that happens.
Excuse me, Trish Alden?
Sorry,
Yes.
you just said if anybody had any questions about
Yeah.
that
Yes,
part.
absolutely.
So I'm just wondering, without giving obviously any specifics, how frequent is it that you are required to step in and discipline in this way?
Every couple of years, every few years actually, I relate the number of complaints we have to other larger provinces, which are probably more statistically valid to look at, and proportionally we're about the same. We receive about 25, don't think we've passed 30, we've been less than 25 to 28 per year, many of which are communication issues and don't reflect a professionalism aspect. And across the country, and including here, about 80% of those 25 to 30 turn out to be something that doesn't require discipline per se, but may require some improved communication. Comparing again to Ontario, when I started this 20 years ago, I looked to see, for budgeting purposes, how often the college here would have to deal with a particularly serious issue. And on the average, looking at the numbers in Ontario, it worked out that we should receive a serious complaint about every 5 years. And over the last 20 years, that's been about what it's been. Gone a bit longer, a bit less, but on the average, that's what it has been. So we're no different from the rest of the country, but it's about that frequency.
Trish?
Thank you. Could you just specify or clarify what would you consider a serious complaint then?
Well, from the patient point of view, they're all serious, and
Right.
we investigate them all. Sometimes it's because it's an issue that should be before the courts and we can't deal with it, because we only deal with professionalism. We don't deal with negligence unless it's an issue that's ongoing. Or it may be that the patient misunderstood, or it may be that the physician had other things on his mind that didn't come across right, but the patient took it up that it's that type of issue. So we use mediation as much as we can in that type of issue.
Okay, thank you. Thank you, Chair.
So the registration part seems pretty basic. You start with a medical school degree. Well, a degree does not equal a degree does not equal a degree. In Canada and the US, the medical schools and the postgraduate training systems are accredited by joint accreditation bodies. The standards are the same. But no one knows how the medical schools in the rest of the world operate. Some we do, but some we don't, and obviously, quite appropriately, we can't discriminate from country of origin based on the fact that we might know a particular school is good or not good. So it comes down to, all across the country, the standard is the World Health Organization directory. Or actually, it's changed to a FAMR directory now. If you're in that at the time the person graduated, it's accepted, you have a medical degree. And it's up to the province where the person is going to determine whether the knowledge gained with that degree is satisfactory or not. Certification in a specialty, be it family medicine, be it obstetrics, be it internal medicine, that in Canada that's accepted as being the standard. It should be a so-called Canadian standard. In fact, we spent about 10 years at national meetings working through to get to that point. And then we get to professionalism, to good conduct, certificates of professional conduct. If I'm applying to Ontario, I have to provide a certificate of conduct from every place I've practiced. We do 5 years because, in our opinion, every place is sometimes a bit too onerous, sometimes we're practicing and moving a lot. But in that certificate, we get confirmation of credentials, we get any discipline record in which if the person has been found wanting, then it's there. And then the next, of course, as you all know, we've had some interest in the legislature around language. The national group set a standard for language, and that's had to be modified. In fact, the province established a very reasonable definition of what is appropriate language skill, and that's the one we use. But the players is where it gets complicated. The Medical Council of Canada was established federally in 1912 to develop a credential acceptable across the country. It consists of two parts, two examinations. The first part is largely multiple choice. There's some write-ins. And that basically is at the level of entering supervised practice. So if you're going into a postgraduate training where you're going to be supervised as a resident, you hope that that person's gotten that and knows the basic medical knowledge. Part two is later on in the postgraduate training, about a year and a half is minimum. So the person has some skill. And there, the medical council hires patient actors who are very good. I've tried a couple of them, and they're very good. They cry at the appropriate times and so on. It's amazing. But they test out and are observed the interaction with the patient. And in that, they do some examination of the professionalism part with ethical values and so on. Medical council is internationally respected, and it's interesting going to international meetings and hear what Canada is doing as being what other people think they should be doing. I'm sorry, going the wrong way here. You know, under the Medical Council of Canada a few years ago, the colleges were saying we need something to assess international graduates to see if they meet the standard. The reason for that is that culturally, people are trained in different ways. In some parts of the world, for instance, family physicians do not do hospital care. In PEI, at least in the smaller communities, we expect the standard to be the same, and they do hospital care. So it's not just the credentials, how actually they've been trained. So the National Assessment Collaboration was established by doing local assessments. Like a number of the larger provinces have assessment facilities that they were using. Those have now been standardized so that one group, one province can say if someone was checked in BC, they're okay for Ontario, and so on. And so the Faculties of Medicine, the Federation of Medical and Regulatory Authorities, which is basically all the colleges' registrars, Royal College is a specialty group, College of Family Physicians, the Collège de Médecins de Québec, an international graduate, have all come together to organize this. At the present time, nobody who's internationally trained comes into Canada, gets a residency position in a university without passing that. So we wanted them to establish a system for practice ready. That's one of the problems smaller provinces have. How do we know somebody's ready to step into a practice? And so they do, and now they have that established for psychiatry and family medicine. Passing that should represent ability to pretty well step into a practice. Physicians apply. The Medical Council with the Federation a few years ago established a national application process. Every province uses it. Ontario uses it for international graduates. I think the rest of us, I'm not sure about Quebec, they use it. But the rest of us use it for everything. So somebody applying for licensure in PEI goes on the Medical Council site, goes in a portal, fills out the application form, press the button as to which province they want it to go to. It's all, and that's based on the fact as well that if I'm applying to Ontario, I'd have to send all my documents in to be verified. Medical Council through the US does what they call source verification. They want to make sure that I didn't fraudulently on my computer make up a certificate. which has happened. Not here, but it has happened. We've had false documents here. So they go into a repository once they've been assessed, and they've got people around the world who can go in and find the records and say, yes, that person, yes, and send it back. So once it's verified, they no longer have to carry their documents with them. I was told one time by the former registrar in Newfoundland, he still remembers the time when, this would have been 30, 40 years ago, when they insisted they had to see the actual document. So somebody brought in the coffee table because he had his LMCC laminated on the surface of the coffee table. Now we're at least better than that. We've got electronic basis, and they are source verified. When I started as registrar, we had to try to do that ourselves, figure out, is it false, is it not false, is it true, you know. This is a lot better. So that's physician apply. The Federation, as I mentioned, is the organization. It's no authority in legislation. It's consensus building. It's communication building. It responds to national issues based on what the provinces indicate. For instance, they were very involved in the MAID legislation. So and they're the ones who dealt with what was then the agreement on internal trade and tried to get a consensus across the country of uniformity to get the standard, to see how you can achieve the standard for international graduates. It's now mentioned the Canadian Free Trade Agreement. So this, we come back full circle to the Canadian standard. A medical school is listed in the World Directory of Medical Schools. A licentiate of the Medical Council, which means you've achieved since 1992 or three, both parts, and before that one part. Like, I'm old enough that at that time there's only one exam. Now there are 2 exams that have to be achieved. If they've completed the postgraduate training that's appropriate, and this is where we all have some difficulties, not just PEI, every province does, because if you come from a part of the world where the medical schools are not accredited, and then there's no standard for the accreditation, and you're training at postgraduate, you don't know if a particular country teaches in the same way. I'll give you a simple example. US and Canada, anesthesia. The anesthesia program in the US is 3 years, and Canada it's 4 years. And the Royal College insists on that. The extra years, I understand, is 6 months of research and 6 months of intensive care respiratory therapy. In Canada, they need to do that in some hospitals. In the US, they don't need to do that because the intensivists do the respiratory care and internal medicine. They still can pass anesthesia fine. And we have licensed people from the US who are not eligible, never will be eligible for Royal College because they don't have 4 years unless they go back and do a year. But they're still capable to give anesthetics. So we have licensed people in that specific situation in areas where they aren't required to do what their training has missed. And that's the sort of nitpicking that we have to do, because you don't want to put somebody, because they have a license to do anesthesia in an area where they aren't capable of doing the job because they're missing part of their training, because they're just different. Not that they're any better or any worse. They're just different.
Is the UK 3 or 4 years?
Hey, pardon?
Is the United Kingdom 3 or 4 years?
United Kingdom?
Yeah, for the anesthesia.
It's a different system. It's a little more, it's difficult because you go through a list of registrars, then you get to a senior registrar's position, and then you do an exam for membership before you get there, and then you get an exam for completion of specialty training, and then, but you don't practice independently until there's a spot opens up and you get your consultant status. So some people can be waiting years before they get the consultant status. So we like to see people who are working independently and not sheltered environment where you don't know how much they're doing, because the next person might be doing more of the anesthetic than they are, this type of thing. So Britain is difficult that way. Good training, but it's hard to equate the two.
Sure.
And we mentioned the World Directory of Medical Schools and the accreditation. Certificates of professional conduct is, as I mentioned, we've tried to make that as uniform as we can. Could go further. A few years ago, the Federation listed what standard format would be like, and some of us adopted it and some provinces didn't. But it's what we require as being absolutely essential, because what we deal with a lot is physician behavior. And the competence is rarely a cause for a complaint, occasionally, but it's usually some interaction that rubbed people the wrong way or was clearly unprofessional, and that's where we would like to know when somebody's coming in, is there a record of that? Does somebody had complaints with another college? If so, is it going to be at risk for patients on Prince Edward Island if they're licensed? Or is it something that, okay, they have a complaint, but it was allowed to go by? So one of the things that holds us up, and which we can't make public, ever, is this. If I apply to Ontario and I've had a complaint, it's an open complaint, so we don't know how the college is going to adjudicate it. But we've got no witnesses. Is it the sort of complaint that, okay, let's say it's upheld, would it be a risk to the patients here? Okay, so we ask for the letter of complaint, and we ask for the letter of defense, and then try to evaluate that. If it's something that, heaven forbid, that does happen, sexual abuse, then okay, that license is not going to be granted. But we can't publicize that. They may have all the credentials in the world, but we're still not going to license them. So and also the same goes with legal stuff. If on the application, and physicians are supposed to acknowledge this if they have a lawsuit, if two lawsuits coming from the U.S. perhaps, and or two specialties for their law lawsuits, that may not be important, but it might be. So we want the complaint, we want the response to the courts, because sometimes it takes years to go through the court system, and yet people need the physician, and the physician shouldn't be penalized if it's not so. We try to make a judgment in that regard, but again, it's not something that ever comes to the public, what we're doing. The public hears, but we had this doctor who's well qualified and the college wouldn't license them. Yeah, we want. This is the excerpt from the PEI Medical Act with regard to language. As you know, we ran into some problems at that point, because at that point we were enacting the exact protocol established by the Federation. Thought, okay, this is what everyone's going to do, this is what we'll do. Turned out everybody didn't do it, and it turned out that in that case it shouldn't have been done, but it was. That was our error. So the legislature here passed this, and this is very reasonable. It's very close to what the Federation money is now.
Chair.
Sydney?
Thank you. So it's changed. Is it working in practice? Like, is it to what the barriers were before, after this came into effect? Have you seen a noticeable difference?
We haven't had as many issues come forward, but one of the differences there is that there is the option for other indication for language ability, and we use that. If somebody's going through a residency, for example, University of Sherbrooke, all their education in medicine might be in French. Most people in Quebec, thank goodness, because I can't speak French, most can speak English very nicely. But we have had complaints in the past of physicians that patients just can't understand. So we contact the director of the postgraduate program and get them to send a letter that yes, this person can function perfectly well in English, and the Act permits us to use that. So it's made things a lot smoother.
Sydney?
As far as like examples, though, like are we talking like, you know, multiple new people that have been accepted into the college? Or like, did it happen once? Has it happened a dozen times? Like, you know, what's the level of success with that?
It's so close to what, with the numbers and the testing and so on, it's pretty close to what everyone else is doing now anyway. So people are often coming with the tests. So
Okay.
it certainly hasn't impeded it, and I think it's improved it, but I can't give you a sense of volume.
Sydney?
And since this has been in place, is there anything as legislatures that we can do to improve it even more? Or are we at the maximum, in your opinion, of you know, safety concerns with that language? Like, you know, obviously we have very capable people coming in and we want to no communication barriers, but we want to make sure that we're not you know, turning someone away for an unreasonable expectation. Have we pushed it to its limit, or is there improvements that we could still make on the language issue to make sure that we can license physicians?
I haven't heard anything either way. I really haven't. We've had no complaints in the last few years with regard to language. We still have applicants, and most applicants now do it because most other provinces indicate that they're not going to get into their province unless they've got a test. So there are not many people who push the button and apply to us who don't have the test. So it's I don't know of any way that I've heard that could be improved. Having that out where we can find other evidence that shows that somebody can speak is really helpful.
Sydney?
And just last question on this point, have we turned people away because of language issues since this was?
Not in recent memory.
Okay. Thank you, Jim.
Okay. Okay. Yeah, go ahead. You're doing great.
So this, in fact, is the language scores that they require, and which is just a little larger print. But the other issues, of course, are cultural, and it's physicians are people. They bring their culture, they bring the way they grew up, they bring the way they trained. One of my favorite quotes is, "We're part of all that we have met." I mean, a physician is a person. So they're going to have their cultural biases, like we have our cultural biases. And that's particularly difficult to decide. I remember about 15 years ago, we had a candidate from Libya who ended up deciding not to come. But I had an opportunity to speak to him for probably half an hour, so I asked him, in a Muslim country, how are you trained in obstetrics and gynecology? What do you do? He said, well, what he said was that the medical school has rotations in parts of the country where the culture is not quite as rigid.
Wow.
And that's the way they get their training. I would have had no knowledge of that if I hadn't sat down with them. We had a very interesting conversation. But those are the sorts of things. We have had complaints about physicians who come from a male-dominant society, and clearly we have had complaints with regard to their overall behavior with regard to women.
Sorry.
Yeah.
Trish?
Chair, so I'm wondering, in those cases then, they're like, obviously, again, without specifics, but what do you do in those situations? How do you manage it? What are the next steps?
We usually don't know until they've arrived.
Okay.
There's no assessment that I'm aware of. I know that the department tries to have an enculturation process, which helps as to what is expected of them in Canada versus their home country. But in fairness, it's really difficult for a physician to suddenly take off the cloak of how they were brought up and come in. And they've been from the same country. There have been some very, very fine physicians and some who've had complaints about that sort of thing. All we can do is try.
Trish?
Thank you, Chair. And I wonder about other issues or sort of personal choice, whether it's cultural or personal belief that might impact a physician's decisions around care. So, for example, I know a constituent has approached me about a doctor who wouldn't treat them or wouldn't take them on as a patient because they use cannabis. So that, where are the lines around what choices doctors can make about who they're treating and how they're treating them based on their personal views or cultural views or perhaps religious views in some cases around care?
Cannabis is a bit difficult per se because it's the use of it has not been scientifically proven yet. In many cases, there's good evidence coming out. In fact, Quebec has a great system. When they started to use cannabis, everybody who prescribed cannabis had to be part of a research project, so more knowledge could be learned. And it was great. So knowledge is coming, but right now cannabis is difficult. But the general philosophy and principle, ethical principles, are that physicians should not be a barrier. I mean, I'm not going to prescribe something that I don't think that I think might be harmful to you. That's what I should do. I shouldn't prescribe it. But if, however, somebody has the right to a particular procedure, let's take MAID, for example, but if I'm a physician who does not believe I should be any part of that cog, then I cannot ethically be a barrier to that person seeking the care they need.
Okay.
I have to either send them to somebody or somehow get them a door that they have the opportunity. The other person may not agree either, or they may, but I can't be a barrier. I can be a barrier if I firmly think that's going to be harmful to you.
Trish?
Thank you, Chair. Okay, so no, thank you for that. And just to clarify, so if it doesn't involve actually prescribing cannabis or anything else, I mean, it just in this, doctors will, some doctors have an interview process when they are taking on new patients. This is what I've been told, and that, this particular individual, it's not the only example I've heard of this, but it's a very clear one, had told the doctor that they use cannabis recreationally, and this doctor said, I won't take you on as a patient if you use cannabis. So I'm just wondering about, is that okay? Is that something that's allowed, or should that patient or that individual be contacting you with a complaint?
In general, picking and choosing patients is frowned upon.
Okay.
In the years ago, HIV was one of those cases where if somebody had misfortune to have HIV and the physician said, no, I'm not going to take you on as a patient, there's only one circumstance that would be acceptable, and that would be if I don't know enough to treat it, but I can't be a barrier. I'd have to take the patient on and refer them to somebody who can treat it. It doesn't mean I have to treat everything everywhere, but because I don't have the knowledge to do that. But I have to be a gateway to get that person help. And I can't pick and choose what type of illness they have.
That's it, thank you. Yeah, this is a specific example, but it helped me understand a little bit about the parameters of what is and isn't acceptable, I guess, in terms of practice, so thank you.
Yeah, that's,
We have Heath McDonald.
Just recently, the premiers met in January here, and they talked about a regional professional licensing. So they're trying to reduce the red tape. Do you know if they've done anything with that, or have their departments or bureaucrats spoke to you as a...
We've had joint meetings. I forget the name of the committee now, but it's from the premiers have a group that sorry, I don't remember the name of the committee. And there's a region, we've met with them, and a meeting was scheduled for February and it had to be canceled. So there's some movement that way to try to do that. I can give you my bias. There are three ways to go, and this is generally accepted by our group, except maybe, I'm not sure New Brunswick has, but the rest of us have. The one possibility is to make uniform all the procedures and the regulations and so on, but leave the acts as they are. Very difficult to do with widely diverse acts. Second way is for governments to distribute, okay, here's a medical act, here's a medical act, you pass the same act. Leave the colleges alone, they administer the acts, but the acts and the regulations are the same. Which I think is quite doable. The third way would be to do that, but also make it one college. There's some appetite for that. But it does reduce the diversity. Every province has its challenges with regard to how to register, where to register, areas in need, every province in the country. So they all make slight changes in order to safely allow physicians in those areas where they might not be allowed in another area. So the larger the college is, the less diverse you can do that. So I'm a little bit shy about that one. I'm not totally against it, but I just think the middle of the road one would work better, in my opinion.
No, I think you mentioned the Canadian Free Trade Agreement. Is that where this is coming from? Because I know there was some discussions that, in regards to trying to ensure that all provinces are likely on the same page. I mean, Atlantic Canada is a little more special because we're so closely related, but is it that different in each of the provinces that it would, there's major impediments, or is it just a matter of organizing the four provinces to accomplish the one society, if that's what you're talking about?
A lot of it's language.
Yeah.
The language in the Act, what we call the temporary and limited register, which really upsets physicians because they can be on that and not temporary at all, but they either have all the qualifications or you're on that register. Doesn't mean you can't practice right along, but the word temporary really irks people. Whereas in Nova Scotia, I think it's provisional there. And in Newfoundland, sorry, I may have that backwards. But everybody has the same type of thing, but across the country, and everybody does much the same thing, which is why we thought, great, we'll just put it all together. But a lady in the college in BC did a ton of work on this. And there are something like 30 different classes of license in the country, which is bizarre, really. But in order to get rid of those, they're all embedded in legislation. And so from the college's point of view, we tried to unify it as far as we could go, but then this province couldn't get any legislation through for this regulation, therefore their name, in Australia, what they did was the federal government simply said, this is your medical act, deal with it. And so each state had the same act. I think one refused to pass it, I think, if I remember correctly, but all the rest of the same legislation.
When was
they
that
had to change the regulation. 6 or 8 years ago, I think. So and none of the acts are really wrong. It's just the language is so different that when somebody applies, it's hard to interpret it in light of your own legislation you're trying to adapt.
So, interesting on the New Zealand stuff, but so do you have any idea what the retention rate is on their doctors there, or if they're in need of doctors or anything like that, based on having 8 years of a modernization of their act?
I don't think, I haven't heard that it changed anything. Australia has an examination for every international medical graduate who comes to them. They do not have a national examination for their local graduates, whereas in Canada we think everybody should be treated the same and everybody has exams.
I'm good, thank you.
Corey, do you go?
Thanks, Chair, and these were kind of similar questions I had too, and I was going to wait to the end, but Heath beat me to it there. So right now, the College of Physicians, is that, if we were to go to regional licensing, is that something you would support?
Yes, in fact, I'm all for national licensure.
Yeah.
Which is what as to quote the Registrar in Newfoundland, let's show the rest of the country that we can do it here, because the ultimate goal is to get national licensure.
Corey?
I was just reading an article about a year ago that these talks had started, or there was talks about pushing this forward. Is there cases where, in particular, the Kings County Memorial Hospital with the emergency room closing often, where we can't access doctors from Nova Scotia or New Brunswick to come over and help out because it's just too burdensome to register here in this province, pay the fees, like a $1,900 fee to register? Is that holding doctors back from that we could access?
Not that I've heard. If somebody has their Canadian qualifications and a CPC, which we can get by phone, electronically, now we can register somebody in an emergency in 2 days.
And would they have to pay the fee?
So the issue is, are they qualified? Are the standards the same? And you mentioned cost. The cost for a regional license will be more. The cost for a national license will be even more. The reason is that that's our funding. All our discipline, all our prosecution of professionalism cases, which costs sometimes $80,000 to $100,000 for a long case, all comes from physicians. And that's where it comes from. So it's not going to be cheaper for physicians, for sure. And my own bias, if it's easier to move around regions, I think we'll lose more than we gain. I think looking at that as the panacea for getting more doctors on PEI, I think is misguided, personally. But that in principle, I think is the right thing to do.
Corey?
So right now, if I was a doctor in New Brunswick and I wanted to come over here and practice for 2 days at the emergency room in Montague, do I need to be licensed in PEI to do that? Is that?
That's
yes.
correct.
And pay the 19, is it 1,900 around there?
It would be if they want a license for a year. If it's prorated down to, we worked out the cost of going through the licensure process, and we set a minimum of 10 weeks, just so we'd cover our costs. But you don't have to be licensed for a year. People who do a lot of locum work back and forth often do get licenses for a year. Then they don't have to go near us at all. They just come, go.
Corey?
So I guess I'm just a little confused. You had mentioned that you would definitely support regional licensing, but then I think maybe I'm misunderstanding you. And then you said if we went to that, we would lose doctors. Is that?
I'm sorry?
Because they can move around easier, you said that we might lose doctors.
Well, I haven't got the data for how many people leave versus how many people come. I haven't heard of people not coming who have a spot to come to. Because of the licensure. They also need to be credentialed by the hospital, which requires more documentation than we do in order to order tests and so on. So it's not just the college who they have to deal with. So, and yes, it is cumbersome, but nothing comes, it'll probably go to you rather than me, but nothing comes to me as far as complaints. I've had a couple of physicians over the years who simply refuse to fill out any forms at all. That's too bad. Too bad for us, too bad for him, but we have to have something in order to verify. And so the coming and going bit, I don't know of any study that says how many people would want to leave versus how many people would want to come. I really don't know that.
Okay, thanks.
Thank you for taking questions during that
Oh,
time.
that's fine.
Keep moving a little bit.
So just to go back to the, about 30% of physicians in Canada now and in PEI, and this goes back at least 30 years, 30% are trained outside Canada. We all know we depend on those people. The next one is the performance must be equivalent. There are 3 reasons for that. One is the patients expect it and deserve it. The second is that as a family physician, if I'm referring to a specialist, I need to know that that person can do what I'm hoping they will do for my patient. So if there are different types of training with the same type of specialist, that becomes very difficult to know, do I refer to you, do I refer to you? You know, how do I decide what's best for my patient? If I know that both of you have internal medicine specialties certified by the Royal College, great. I know what the standard is. It doesn't matter. Which doctor would you like to see? Good. There you go. And the other way is true from the other point of view. The specialists need to know what family physicians are capable of doing, what their training is, in order to know what to expect in follow-up. As a specialist, do I have to follow this person? Does that person have the training to do that? And so keeping the standard about the same is not just a matter of keeping a closed shop. It's a matter of being able to communicate easily what the expectations are, particularly the expectations of the public. So in some provinces, this is the way it works. If you don't get your LMCC, and there are problems with that, LMCC is the standard. If I've been in practice for 30 years, it's been longer, but 30 years, and try to get back and do an exam that people are used to looking at in the training, I'd have a great deal of difficulty doing the part 1. Part 2, I think I could do. Part 1, where it's more basic science, I'd have trouble with that. So people coming from, or just graduated in another country, probably have not much trouble with it. It's online, you can, and I think there are 30 sites around the world you can do it. Before you come, see if you can do it. So if you do that, the evaluating exam, say before 2019, because the last one of its type, which is a watered down part 1 basically, was written in November 2019, so it's no longer there. It was also around the world. Then the provinces who have this go to 5 years of supervised practice. Well, we don't do 5 years. We do, because the physicians who are doing the supervising are volunteering time out of their practice to do it. They have less time for their patients. They're expected to speak to the nurses, review their files, review their treatment, find out, okay, is this appropriate? So as soon as the supervising physician can say that this person is safe, we stop and say, fine. Is that sufficient? I don't know. Other provinces do a standardized 5 years. At the end of the time here, we expect people to get their certification. And people who have failed 3, 4, 5 times in the certification examinations, we ask them to leave. We believe that the patients in PEI deserve the standard that's accepted across the country. Is there a problem getting your certification exams after you've been out for a number of years? Yes, there is. Is it fair? I think it is from the patient's point of view. I'm not sure from the physician's point of view. But that's the only evaluation that we've got in PEI. Some places will do a 360 review. Some people will put them through a course to try to get them and work with them over a number of years. We don't have that luxury. So are there people people not here who might have been here had we got that system? which is one advantage for regional equality. You could do it in a bigger area, like Nova Scotia, and then bring them here. But the data is out there that where people train is where they stay. So unless we do the supervision and the assessment here, there's a good chance that they wouldn't be here.
Trish?
Just a quick question, thank you. So for doctors who are going through this evaluation process, you mentioned that if they fail 3, 4, 5 times, that they will be asked to leave. How do you determine at what point, 3, 4, or 5 times, it just is, how do you determine that cutoff where it's like, okay, that's enough, you're ready?
We use the certifying bodies, the College of Family Physicians, the Royal College. They have very good statistics on how likely it is for someone to pass after you've failed once. It's not uncommon to fail the first time. It's new language, perhaps. It's a new culture. It's a new, fail second time, you raise the issue, third time, and some of them will give a fourth time. But after that, they wouldn't be allowed to write the exams anymore. So that we rely on them.
Trish?
And how often has that happened here in Prince Edward Island where someone has been asked to leave on that basis?
It doesn't happen often. I'm just trying to put it in probably once every 3 or 4 years, maybe. I haven't got that number on the top of my head, I'm sorry. It's not really common at all. We actually have very good physicians who end up coming here, so we don't run into it very often. And it extends over time. This is my problem, because you write the exam perhaps twice a year in a specialty. Well, to get to the 4, that's over 2 years. So which year do you count them in, sort of thing? I don't have that figure, but my guess would be every 3 or 4 years.
That's it for now, thank you.
So which is why we have the only assessment we've got, a summative assessment, is the certification exams. That's why we use it and rely on it. So then I started to wonder, how do we compare to other places? Well, frankly, I don't like the word full licensure. It's antiquated. At one time, 50, 60 years ago, a person was licensed, they were licensed. They could do whatever they felt they could do. No longer the case. If a physician who's, let's say, trying to make it quite obvious, a psychiatrist, fully qualified psychiatrist, and does he have a full license? Well, no. He can't deliver babies. He hasn't delivered babies perhaps since medical school, if then. And so the term full license I find really, really difficult. So some provinces actually have that enshrined in legislation. I think Newfoundland is one of them. But it doesn't exist, because we all have the same rule that if I haven't done something in 3 years, and I haven't delivered babies for longer than that, if I go back to deliver a baby, I need to do it under supervision to make sure I can still do it. You don't assume somebody who's fully qualified can do everything anymore. And that's why I don't like that word. The qualified, fully Canadian standard of certification plus LMCC is reasonable, but we need another word besides full. And we don't require the MCC exams of everyone. Not many provinces do. Some don't require it at all. For a specialist coming in from another country, we usually will require them to have at least evidence of, like the NAC, OSCE, or Part 1 MCC, which can be done online, just to make sure they have general knowledge about medicine. But we don't require the full, and yet they're fully qualified to do what they do. They're fully trained psychiatrists. They don't need to know all the cardiology. All they need to know is somebody who's had a heart attack and get depressed. Then they, it's that sort of thing. So we try to tailor it to what's appropriate. But quite frankly, some people get upset by that because they don't have a full license. And we mentioned the fact that we don't supervise for 5 years. Well, we have had a few, but most of the time we don't. And there's no alternative to the certification. So we already talked about possible ways to be mobile. One is for those of the Canadian standards that I mentioned, it's quite easy. We've got systems in place. If something happens with the coronavirus, for example, and colleges get shut down, we've got emergency numbers. We can contact other colleges to take over the role. That's been in place for quite a number of years. The possibility of a Nexus card approach, which Dr. Gus Brandt, Registrar in Nova Scotia, really likes, and that is put a physician through, you got to make sure they have all the standards, make sure they have an up-to-date certificate of professional conduct, and then they get a pass for so many days. You go over and do the 2 days in Montague, or whatever is required. So that would provide easier, and that's one approach. And that may be where we end up with the regional discussions. I don't know where that's going to end up, but I think we aim high. Hopefully we'll get there.
Sorry, I
Just while you're on that, is there docs that are willing to move around? Like, we hear a lot about nurses that just recently graduated, don't want full-time work, they just want to kind of move around, do a little bit of traveling until they get their life straightened out and settled. Are docs similar to that?
Very similar.
So
new graduates really, some do, but the most don't, at least ones we see, don't seem to want to settle down.
So in saying that, back to kind of Corey's comments on the locums, if the 4 Atlantic provinces made it much easier to move locums around, in instance of those ones that aren't willing to settle down and want to golf in PEI on Saturday and golf in St. Andrews on Sunday, but maybe come over and do some work in the meantime, or something to that effect. Is there something immediate? Because, I mean, everything you read for the future of Atlantic Canada economically, the aging demographic is pretty severe, and healthcare is going to be the thing that likely burdens any growth whatsoever. So I'm just kind of wondering, back to Corey's comment, is there anything at the least that you can do to eliminate the barriers for these locums to move around, at least the 4 Atlantic provinces, but obviously maybe Canada, I don't know, but I guess it just seems like there's something there. And I was reading comments on, I think Stephen McNeil was the one that said it, I can't find it now. But it was something in reference to Nova Scotia Premier says the colleges that regulate physicians need to modernize and be more flexible if they want to make patient care a priority and keep doctors in the province. I know he likely doesn't have a great relationship with what they went through with docs, but I'm just kind of wondering in the locum thing if that's a short-term solution for your organization to really pursue, or somebody.
Well, that's what we're looking at in the regional meetings, is how can we do that? You also need to look at the converse. It's not good for patient care. It's not good having walk-in clinics, emergency, where people come in and do a Band-Aid approach. Who's going to follow up if they leave after 2 days? It's not a substitute for having physicians in place. As far as the urgent stuff, if somebody is qualified, they can move now. The cost, that's what we're trying to sort out. It's not going to be a barrier, it's just a matter of deciding what the cost is going to be. Should we go the way the lawyers go, in which case somebody can go to another province for a particular case? Well, the problem with that is, of course, that people come to any province as a physician and see 50 cases on a weekend. It's not one case. of which many will need to be followed up. And if you're not here to follow it up, they get lost. So it's not an easy answer. Easy mobility is not the answer to manpower, in my opinion. It's great for the physicians, no question. And I'm not anti-physician, I am one. And it certainly would fill the bill of somebody closing an emergency.
Yeah, I guess that's what I was more referring to.
It doesn't fill the bill as far as protection of and patient safety and long-term care.
Okay, thank you.
Lynn Lund?
Thank you, Chair. I appreciate your presentation so far. Thank you. It's been very informative. My understanding currently is that there are healthcare shortages in all of the Atlantic provinces. We are struggling to retain doctors. So to the point of my colleagues, I'm not sure that we could fill the gap by moving around the players that are already into the system in the Atlantic provinces. It sounds like we need to be bringing in new people more so than just moving around the deck chairs, if you will. Is that a fair statement?
That's a fair statement.
Thank you. So I'm curious, how many of the applications that you receive would you say are rejected currently? It seems
Glad you
that
asked.
the rubric, pardon me?
I'm glad you asked. One of our staff did this at the request of our office manager, which is great. These are not full-time physicians. These are new applicants coming in and leaving and so on. 2018, there were 96. 2019, 95. And 2020 is on target, but I don't have the number for that. It's on in a couple of months. Of those people, the 27 of the 96 in 2018, 27 were licensed from the time they applied until they were actually licensed was 27 days. Every other college counts the time for licensure to the point when all the material's in. When we get the application electronically, we still have to get references, we still have to get CPCs, we still have to get the confirmation of the documents, which electronically is great, it can happen the same day. But if it's not, it takes a while. So there is the gap and the question how long it takes a particular physician to provide that. So having it centralized, like medical council is over 1 million documents now of physicians. So it's being used and it makes it a whole lot simpler for us. So, but this is from the time the person presses the button and says apply to PEI. And we get it the same seconds later. So there's a little misleading because we can't license them after we have some of that other stuff. But it's a way we can measure it's accurate at least. So 2018, 96 applied, 27 under 30 days, 38 between 30 and 50 days, and it took 41 over 50 days to be licensed. Of those, 15 of the 96, 15 withdrew or were declined. Most withdrew. We don't decline a lot. We might decline maybe a couple of months, maybe less than that. No, it wouldn't be that many. So 15 over 1 year didn't follow through for one reason or another. And 2019 is very similar, fewer actually, percentage-wise. 95, 29 less than 30 days, 35 between 30 and 50, 31 over 50, and 13 withdrew.
Lynn?
Thank you,
So
Chair.
the numbers are pretty stable.
Thank you, Chair. That's very helpful. I'm curious if you've noticed main themes or reasons around the people who do not make it all the way through the licensing process. It sounds like the rubric for how you assess whether or not someone is going to get this is complicated, and some of it's really quantifiable, but some of it is subjective. So I'm just curious if there are any obvious themes for the reasons people do not receive their license.
On the ones that were declined, I better handle on. It may be that we can't relate their training in a certain part of the world and know how reliable it is. There's one country a couple of years ago, for example, that quite a number of people, over 100 people went to jail because they were bribing and the accreditation of the program. one other country in the world that decided they weren't going to take any people from that country anymore, which I think is overkill. But that's, so that sort of thing happens. But in these cases, it's sometimes because they've then had a site visit and decide it's not for them. A family doesn't want to move, or family circumstances, or they've applied to 2 places and they decide to go to the other place. That sort of thing. It's not usually, unless they come in January, it's usually not the weather.
Lynn?
Thank you, Chair. So those sound like the circumstances where the doctors themselves decide that for whatever reason, this isn't a good fit for them. I'm curious, on the side of having those applications rejected, is there a main theme on why that might be? It sounds like the numbers are small, but I'm just curious if you've noticed
The
any
big
trends.
3 would be unresolved complaints or legal cases that seem to be of issue. The lack of a postgraduate qualification that suited the place that they were going to go to. It may be somebody who did nothing but laboratory medicine for a few years and then applied to go to a rural place in PEI and needed to have so it's that type of thing.
That makes sense, thank you.
Great.
So these are some of the difficulties that I perceive. People don't achieve the Canadian standard because of examinship or being in their specialty too long to be able to achieve it. They don't want to have to get their Royal College because they're especially trained in another country, but we have no idea what level of training that is and we have no way to assess it. And we talked about the easier mobility, and I still think in principle regional licensure and national licensure should be the goal. But the big barrier, in my opinion, is provincial legislation is so variable that it makes it really difficult to pull somebody from one area and know where they should be in another area without either giving them too much credit or usually not enough credit for what they can do.
Trish?
Thank you. So you mentioned that regional talks are underway then to possibly standardize across at least the Atlantic provinces. So what role does government play currently in those discussions?
Well, as you know, the Premier's mandated that this will go forward. And so, I'm really sorry, I don't remember the name of that committee, but anyway, they contacted us and met with each of the provinces. We had a meeting in Charlottetown of the registrars, which was scheduled. They came, we talked about it, didn't hear anything for 6 months. Then they said, well, we'd like to meet again. So we met by phone. And then now we're anticipating a meeting with at the deputy minister level, or their committee level, and the registrar and our president. And that was the one we had to cancel.
Trish?
And so there's equal representation then from all the 4 Atlantic provinces, all governments are committed to being involved in these discussions, at least at this point, to possibly standardize the legislation?
I don't know about New Brunswick.
Okay.
New Brunswick has said that they would be there as an observer at the moment and make a decision as things went on. So they're including them in the discussion. I mean, they're part of the discussion, but I don't think their government's made a decision as to what way the other, as far as I understand, the other 3 provinces are committed to work toward it if it can be achieved.
Trish?
That's it for now. I do have other questions, but I'll wait to see.
Yeah, great. Excuse me.
It could be Council of Atlantic Premiers, is that what
That's
they're
where it
referring
came
to?
from.
Okay. And the other thing, I just referencing my colleague there, but when I was talking about locums, I was talking about emergency rooms at the Kings County Hospital to be filled by the locums. I wasn't necessarily talking about long-term taking a doctor out of Nova Scotia to Prince Edward Island and coming back and forth. I was talking about emergency purposes, that on holidays and what have you, that we're closing emergency rooms. So I just wanted to clarify.
Sure. Thanks, Cyril.
So we talked about this, let's go over it quickly. So physician mobility is currently assured, but could it be faster? Hopefully. If the practice is current, and if there are no outstanding discipline issues, communication issues like language, similar class of registration is a barrier right now under the free trade agreement, because I'll give you an easy example. PEI does not have medical school. All the other provinces do, and they have a class of license, I'm not sure they all do because I haven't looked at this, but most of them do, called an academic license. So they can bring somebody into the university setting as a teacher who is particularly good in whatever, from whatever country, and they can be licensed within that university setting. As soon as they lose the faculty appointment, they lose their license. So somebody who's got an academic license, this has happened recently, applies here. We don't know how much independence they've had in the university. They don't know how much teaching versus actual work they've been doing. They're not licensable without the academic license, and we couldn't take them. They may be superb, but they wouldn't have been licensed except for that category. So that's where it'd be very, very helpful to have a legislation similar. And the cons, the standard they often can't achieve, not often, a lot of them can actually, but some choose not to, or they come here in a time of need, we have them under supervision, they work with, say, the Royal College to get there, but then they work so hard they don't have time to study. And I don't know any of us who wants to go into an exam who haven't at least refreshed ourselves in studying. One of our council members pointed out that Canadian graduates in specialty training have almost weekends where they're dedicated to practice the training, practice the exam, practice the orals. We don't give our international graduates who are helping us out the opportunity to do that. They're set up not to succeed. So those who succeed are quite remarkable, and I know a number of them.
Sorry, Trish?
Thank you. Sorry to interrupt. So that's very interesting to me. So I wonder if, just in your opinion then, or in your experience, if international grads who are, we're trying to reach out to them or to recruit them, if it were known that we did provide that time for them to be able to study, if that were part of the recruitment process, do you think that would help?
I think it would help, personally. Depending on the individual, of course, but I think it would help because I don't think anybody wants to be considered a second class of a physician. We really work hard to try to help people get through the Royal College application process and get them to the exams and so on. And we have to be supportive of that in writing in order for them to do that. So we spend a fair bit of time doing that. But then to learn that they haven't had the opportunity to bone up, because writing exams is a little bit different from in practice. You have to be right there and then. In practice, you usually, except in really dire emergencies, you have the luxury of sorting it out. Well, this is the way you start. This is the way you always start with this. Let's do what we do next. It doesn't work in exams. So that sort of thing is, I think would be a help, yes.
Can I ask one follow-up
Sure,
question?
Trish?
Thank you, Chair. So along those lines, are doctors granted any time to work on publications or anything along those lines as well as part of to work on publications perhaps, or to have some time to step away from practice to work on those pieces, things like that?
I don't know.
Okay.
I have to ask Health PEI that one.
Okay. Very well.
I don't know how much time, I've not seen it, but then I would have no reason necessarily to see it. Most people I know who've published have done it all on their own time, nights, weekends. But I don't know. Good
Okay.
question.
Well, thank you. We'll definitely look into it because could be another incentive to recruit if people knew they had that time to do that. So thank you.
So the difficulty is the standard of training, and nobody wants to suggest that international medical graduates are not well trained. But they train to a different level at different stages, and trying to, because of the necessity of physicians knowing what the person can do and can't do, we try to get people to get the Canadian standard for their own benefit. Number one, it makes them more mobile, but also it gives them the sense that they belong. They're part of the Canadian medical establishment. They're not just filling in. And I think it's important personally for the physician and retention. If they can achieve that and with their colleagues, I think we're all better off.
That's a great presentation, and right now, you're feeling okay? We're
Yes,
not,
yeah,
you're doing a great
hoarse,
job.
but-
This is very important, so yeah, have a drink of water, and so we'll open it up to any kind of questions that we have now, and then if anybody, I'll just start with a quick question. You know, as the world moves, we see more and more technology being used and us going online, and you know, in Tignish, they're working remotely with the doctor at different times, and it seems to be going well. With the doctor was on Prince Edward Island. What are some of the barriers to moving forward over the next 5 or 10 years about using internet technology around the registry? And is that going to be something that we can put in place for Islanders to get adequate care in the future?
The word adequate's interesting. That's in the eye of the beholder a bit. That's a really nice door to open. It's got a couple hours. No, it's across the country. It's with regard to the basic what we're doing, telehealth, so on. Across the country, it's interesting. East Coast, eastern half of the country, almost. Not sure about Quebec. The principle is that if I'm practicing medicine, I'm practicing where the patient is. If the patient is in Halifax, and I happen to know the patient, they run out of pills, and it's my patient, I still have that doctor-patient relationship, and I should be able to renew their pills for them. If, however, it's somebody I don't know, and I decide to, by Skype or whatever, to make a diagnosis and prescribe something, I don't have the relationship already there, then I'm really practicing medicine in Nova Scotia. Because that's where the complications are going to be. That's where if there are going to be any, hopefully not, but if there were. The western part of the country, they say, well, you can't regulate that, therefore it has to be where the doctor is. Which, my own bias is that's illogical, but anyway, that's fine, they're my colleagues, they do that. And that's been an issue. So what we have said is that people, the patients, as we try to look at things from the patient perspective, deserve the same standard of care as if I were in the same room with them. And that's really hard to achieve. Some things you can, but it's really hard to achieve. The patient, on the other hand, has some responsibility not to dial up a doctor who happens maybe to be halfway around the world, and you don't know what the standard is. So we can't regulate that. That's free internet stuff. So what we've done, and people have been very, very agreeable to it, and I think it makes sense. If we try to rely on that doctor-patient relationship, we expect the physician, the family physician in particular, to keep records of that exchange, to send the records to their family doctor locally, to make sure that there's the chart contact. And to do that, we've had to ask them to be licensed here. And most people who are doing this are in companies. There are a lot in Ontario who are doing that here, and and it's, as far as I know, it's worked out fine. But the door that you opened by the question is, I'm on a working group for artificial intelligence with the Federation, just to look ahead. In what way, or what physicians need to know in 10 years when a lot of the investigation and training is going to be internet-based anyway. And the role of the physician is going to change a lot.
Yeah, and are we positioned well in Prince Edward Island to entertain that?
You know, we may not need physicians in some parts of the country.
So I'll just, I'll open it up for everybody to ask. I know we'll start off with Trish, and then...
Thank you. Now I want to ask about AI, though, that in 10 years you think it's going to have that, I mean, that's very interesting to me. I had looked into, I'd not looked into this in great deal yet around the impact on doctors, so I find that, maybe I'm just going to ask you if you could elaborate a little bit on that, what changes you might see over the next 10 years then in terms of our need for, you know, doctors. I was shocked by what you just said. I'd like to know more.
Well, I was too on the first meeting. I sit on the executive board of medical council, and they design the exams, which is where this came from initially in my experience. So they have to look ahead about 10 years by the time they structure the exam, test the exams, so it's available for people. So they have to look ahead and try to figure out what a physician is going to need to be taught and know in 10 years. How much are they going to have to be? Is the computer going to be an aid? Is it going to be the first point of contact and then it goes to a physician, which will reduce the numbers? Or say a radiologist, for example, computers can do, for some tests, a lot of the reading of films. So is the radiologist going to only be an interventionist radiologist? That sort of thing. So we did an exercise with the Conference Board of Canada facilitating, trying to figure out, okay, what role will the physician have, and therefore, what do they need to be examined on? Because the development of the exams has to start pretty soon. So it's all, and that more recently though, I've heard that, okay, this may be a bit exaggerated to read. But it's going to change things a lot. But how, I'm afraid I can't answer yet.
Trish?
No, it's very interesting, and it sort of leads me to questions around something that you'd mentioned earlier around that PEI doesn't have a medical school, and that's part of the discussion that has come up. You know, should we have one, and what would that look like? And when, you know, by the time we have that in place, and we graduates from a medical school here in Prince Edward Island, you know, 10 years is a pretty short amount of time. I'm sure you don't have any answers to this question, but it's sparking some things in my mind. You know, is that the right investment if long term, exactly, if we are not going to be needing as many doctors perhaps as near in the future as 10 years? Just, I don't know if you have any comments on that or any thoughts on that, perhaps not. It is something just came to mind as you were talking.
Yeah. The present situation is a little bit easier to comment on. The medical schools rely a great deal on the volume of patients going through the care system. It's very much a system of teaching physicians by observing. You can read all you want, but to actually see a patient with a problem, it's not really real. So to have a medical school, and this is why the cities have always sucked up the medical schools, because they have larger hospitals and the volume is there. Now more and more training of physicians is out in the community, which works really well for family physicians because that's where most of the care is. But again, it's the volume going through. You wouldn't be able to teach a neurosurgeon neurosurgery on PEI. You just wouldn't have the volume to make him good. And so which is an issue with regard to artificial intelligence, because I'm a firm believer that I don't know an abnormality unless I've seen an awful lot of normality. And if the AI system takes most of the normality away, the routine stuff, then the physician is only dealing with what's abnormal. I'm not sure what effect that will have on care. So it's really a dog's breakfast right now.
It's very interesting. I won't ask any further questions on that, but perhaps we can have a discussion at a later time, because it's quite a rabbit hole of sort of trying to figure out what's going to happen next. Very interesting.
It's a fun discussion.
So, yeah, no, it is. I will go back. I did have just sort of a practical question, just to make sure that I understand fully the process. So when a doctor applies for licensing here in Prince Edward Island, is that doctor, have they already been offered a job here in Prince Edward Island, or would they, what comes first, chicken or egg here?
Yes and no. Our policy, this isn't by law, just a policy, is that we will license anybody who's qualified. So if you live the Canadian standard and apply to us, we'll give you a license. Whether you've got a job or not, sorry, that's not our department. If somebody does not have Canadian qualifications, they require a lot more work to figure out whether they're able to, what supervision is required, and we have to find a supervisor, and the department helps with that. You know, so there's a lot more work involved, and with the internet, you can get hundreds of applications. So rather than spend a lot of time on applicants who aren't even required in the system to see, well, yes, you have a license if you have a supervision at a level 2, which means someone has to be with you all the time. We can't afford that. We're not big enough to do that for everybody. So we rely on the recruitment people and the department to say, we need a Dr. So-and-so up there, and we think from checking the references, we think this person would work. What do you think? Then we'll put the work in and say, well, yes, that person would be good. He probably needs to be supervised by phone for a bit, or he needs somebody by his side for a bit, but whatever it looks at. So if you have Canadian qualifications, we don't look at that, we just license them. If you don't have Canadian qualifications, we like to know there's at least a place for them before we put the work in.
Okay, all right. Just one quick follow-up on that, and then we can move to the next person. That I do have other questions, but so just so that's the usual process then, is that someone would already have a position, recruitment and retention folks would let you know they have someone in mind, and they would check with you to see if you think it's a good fit. Does it ever work the other way, where someone applies for a license, they get approved, and then they don't have a job here, or they're not offered a job for some reason?
Once or twice in the last 20 years, we've licensed somebody with...
So not often?
Not often.
All right, thank you.
Lynn?
Thank you, Chair. So just jumping off of something Trish said, I'm just looking for a little clarity. You had indicated that about 95 or 96 people on average in the last couple of years have applied for applications. Most of those people received their license. And just for clarity, most of those people are also now employed on PEI?
Most of those people would be short-term licenses, which is why the volume is so high. Because there are parts, as you know, of Prince Edward Island who rely heavily on people coming in and leaving. Some will come in for 3 months and leave for 6 months and come back. Well, they wouldn't have to be relicensed, or at least half the work's already done, so it's quick. So no, that's sort of all comers, just all applicants, except it does not include the people who are relicensed and are permanent each year. You know, like I've been here so long, growing roots. But so I apply every year. I wouldn't be in that. These are people who are not currently here.
Lynn?
Thank you, Chair. So for clarity, those people would predominantly all have been offered jobs.
Yes.
Fantastic. Thank
Well,
you.
I don't have it divided up as to Canadian standard already have or international graduates. Those are just they're not all international. They would be next year.
Thank you.
Just taking this year, 2020, and you as the registrar, I'm not sure if you know this, but if you look at 2020, I know you gave us some numbers about 2018 and 19. As the year started off, have you received a typical amount of applications in the first 60 days of the year?
That's what they told me today when they gave me those numbers.
Yeah. So I'm just trying to figure out if if it's when the most of your applications come in, or you don't have any data for this year or the last 6 months? Is it on track?
Not specifically. I'll tell you when it seems to be the busiest is April to June, because welcomes are brought in for people on holidays.
Yeah.
So that seems to be at the busiest time.
Yeah.
But I don't have the data you're seeking.
Yeah. And when people leave the island, does your organization are you involved in their, I know you're part of the registration process, but do you get any information from doctors on the way out, why they're leaving, what was good about Prince Edward Island, choosing rural versus urban, anything like that?
We don't.
Yeah.
And often we don't know they're leaving.
Yeah.
If they're licensed for, say, 3 months or 2 months, then sometimes we have to find out, do we seek from the department, does this person need to be renewed? Because we don't want to be at the last minute scrambling to do something that could be done a month ahead. And, well, this person yes, this person no, this person, but we don't have any information as to why.
Is this a problem? Are all the organizations talking to each other to make sure that everybody's in the know about movement of doctors? And would you like to see that process sped up a little bit?
I'd like to know why, because I'd like to know if there's something that we can do about it.
Yeah.
We're a small cog in the wheel, but there may be something. What I've sought, and I thought we were going to get, but things changed. Anyway, that's fine. It wasn't anyone's fault. But what I'd like to know, and then you run into legislation and privacy concerns and so on, I'd like to know specifically about the people we licensed who did not work out. Either through issues in their work or whatever reason. Because then we can we might be able to modify what we're doing up front and minimize the number of people who come in and leave because it just didn't work out for them. Is there something we can do to help screen for that? Give them more supervision, whatever. But so to get that feedback, on the other hand, we do have to be really careful that the boundaries are not blurred between registration and licensure and recruitment.
Yeah.
And likewise, health PEI has to be really careful with employer-employee relationships. They don't share stuff that they're not supposed to. So it'd be really nice to have, but I'm not sure whether it would be appropriate.
Good answer. Yeah, Trish?
Just one more question, and this is just again for me to understand a little bit more about what is covered under the college or what the role is. In terms of determining the complement of doctors or making changes to the doctor complement, does the college have a role there, and what does that look like?
No.
Not at all.
Strictly medical society.
Okay, perfect. Thank you. That's it.
Great. So I think we're all done our questioning. So what we'll do right now is, like, if there was one last thing that you would like to see after chatting for this amount of time, and it was great, in our report to the legislative sitting here, what would that be? One or two things?
One or two things?
Yeah.
My bias? I really would like to see common legislation right across the country. I really would. I think it'd make life a whole lot easier for everybody. Because we all do the same thing. We're all looking at the same standards. And they have that many different classes of license just seems to be a bit odd. But I really would like to say how much I appreciate your doing this. It's really, really very helpful.
Yeah, it's a great committee. Well, we want to thank you on behalf of the committee. We want to thank you for coming in today, and it was a great pleasure to have you. And if there's anything else you can think of, you can always send us a written correspondence, and we'll be sure to send it to the committee. So
Thank you very much.
Thank you very much. And what we'll do right now is we'll take a short 2-minute break and come back and finish the meeting. Okay, we'll bring it back and to the meeting. And number 4 on the list is just a quick update of our work plan. As our PREO schedule develops, it looks like we'll be having meetings every week until the House sits, from now until April 1st. So March 11th is the PEI Lung Association. They've confirmed. Also, next week, if you could go back and talk to your caucuses, that we will be starting our in-camera work plan next week after the presenters. So we're going to start to get our plan ready next week. So that's an important week too. So March 18th, we have the PEI Nurses Union, and Mike Redmond has confirmed he will be speaking. March 25th will be Canada Games representatives. They're confirmed. On April 1st, Health and Wellness, Recruitment, and Health PEI reps, and Kings County Memorial Hospital have all confirmed on that date. And I think April 1st will probably be our last opportunity to invite guests, and then the ledge will be back in there. So does anybody have any comments on those 4 following weeks? Anybody? Good. Okay, so we'll move on to number 5, which is new business at this time. If anybody has any new business to bring up. Nope. Okay, perfect. Sean, is there anything that you need to talk about? No?
Not really, it's
Okay.
all there in the schedule.
Great, perfect. Okay, so at this time, we'll move to adjourn the meeting. Can I get a motion for adjournment? Motion for adjournment. Heath McDonald. So then this meeting is adjourned.